Hello everybody and welcome to this lecture on the Coombs test. So the Coombs test is split into two different types of tests. And before we go into those, just generally speaking, you use this test to detect autoantibodies against red blood cells in the blood. And the two types of Coombs test are the direct and indirect. So here I laid out the two types. Direct, your reagent is going to be the patient's blood, as well as anti-human antibodies. So you take a sample of patient's blood, and then you're going to add in anti-human antibodies, and I have a graphic coming up that'll explain this a little better. And it'll be positive if your patient's blood has anti-RBC antibodies attached to the blood. Okay, so anti-RBC antibodies attached to the blood, your direct Coombs will be positive. On the other hand, the indirect, you have three reagents here. The patient's serum. So this is the plasma that you get, not the RBCs, not the red blood. So you'll do a blood draw and you'll spin it down so that you could split the plasma, the serum, and the RBCs, and you'll use the patient's serum in the indirect. Then you're going to use donor blood that you know does not have any anti-RBC antibodies on it or in it. So it's just normal RBCs, which is your donor blood. And then your third reagent is the anti-human antibody. So remember that both indirect and direct, you add in the anti-human antibody. And just like the direct, the indirect is positive if there are anti-RBC antibodies present, but this time if it's in the serum. Because remember, your patient sample is serum in indirect, and direct RBCs, the blood. So that's the biggest takeaway from this is direct, you're using your patient's blood. Indirect, you're using the patient's serum. And if you can remember that, the rest you can kind of piece together, honestly. So let's go into some examples and diagrams that I've put together here. So the direct Coombs test. On the left side of the yellow line is your reagents, and the right side would be the results. So let's look at the reagents here. The first thing you have is your patient's red blood cells with or without anti-RBC antibodies bound, because that's what you're testing for. So you don't know if they're there before you do the test. That's why you're doing the test. That's why you do a direct Coombs test, is to see if your patient's red blood cells already have anti-RBC antibodies. So here you can see, obviously these are the RBCs, and the green antibodies are anti-RBC antibodies. So in this would be a positive sample, but we'll get there. So that's the one reagent, and then after that you're going to drip in some anti-human antibodies. This is also called Coombs reagent. So that's kind of where the test gets its name, is the Coombs reagent. And what these antibodies do is these antibodies will bind to anti-RBC antibodies. So there's a lot of anti in this language, so it can get a little confusing. But again, I'll say it again. Anti-human antibodies, aka Coombs reagent, bind to anti-RBC antibodies. So when you look at the results, a positive test, which would happen in somebody who has anti-RBC antibodies, causes agglutination. So viscosity would increase in the sample, and it would agglutinate. And why would it agglutinate? Because your anti-human antibodies bind to anti-RBC antibodies, and it kind of causes this mesh-like framework, so it agglutinates. Now, if your patient did not have these anti-RBC antibodies, as we see here, your Coombs reagent, or your anti-human antibodies, wouldn't have anything to bind to. So there wouldn't be any sort of mesh framework, there wouldn't be any agglutination, your RBCs would just float around like normal, so you have no agglutination, you know it's a negative test, you know your patient's blood does not have any anti-RBC antibodies bound. Okay, so I know this can get confusing, like I said, because of the anti language. So watch it a few times if you have to. And now we'll look at the indirect. The indirect, like we mentioned earlier, you have three reagents. Your first, remember, indirect, you're using your patient's serum. So your patient's RBCs are not used in the indirect. You're testing to see if the patient's serum has anti-RBC antibodies. So this one, for the diagram's sake, we show that it would be a positive test. The patient's serum does have anti-RBC antibodies, which are the green antibodies again. Then you're going to add your Coombs reagent. Remember, this is the same in both. Coombs reagent, which is also known as anti-human antibodies, the antibodies that bind to anti-RBC antibodies. And then finally, you're going to add in some donor blood. So think of this as just normal RBCs. You don't have any anti-RBC antibodies attached to this blood, just normal RBCs. So the result side is very similar, actually essentially the same as the direct. It's going to be positive if, once again, the sample agglutinates, because what would that tell you? Here's your patient, or your sample, your donor RBCs, your normal, and if it agglutinates, then you know there's anti-RBC antibodies in there, and the only way they would get in there is from your patient's serum. And again, they agglutinate because the anti-human antibodies, aka Coombs reagent, binds to the anti-RBC antibodies, creating this mesh-like framework. On the other hand, if the patient's serum did not have any of these anti-RBC antibodies, you're not going to have any agglutination, and things are just going to be floating around in there like normal, just like in the direct Coombs test negative result, right? Because your Coombs reagent, aka these anti-human antibodies, don't have any anti-RBC antibodies to bind to. So there's not going to be any agglutination, no mesh-like framework. Again, I know this can be confusing, so listen to it a few times if you have to. Lastly, I'll just briefly go over a few common things that a positive test result represents. The boards like to test what the positive results could mean. The absolutely number one biggest thing, both in, well, especially on the boards, but in real practice as well, is autoimmune hemolytic anemia. So whenever you have a question on the boards about autoimmune hemolytic anemia, Coombs test is probably going to be incorporated somehow, whether it's in the answer choice or in the clinical vignette, because the very basis of autoimmune hemolytic anemia is that you have anti-RBC antibodies in the blood that are lysing RBCs. A positive test result can also be a sign of leukemias and lymphomas. Hemolytic disease of the newborn is another big one that you might see on your PED shelf, or even USMLE, but more likely PED shelf. That involves the Coombs test, can be used to help diagnose this. Mono actually can present with a positive Coombs. Lupus, which makes sense because you think of lupus is an autoimmune disorder, so, and a lot of other autoimmune disorders can have positive Coombs as well. And then, of course, transfusion reactions. And that concludes this lecture on the Coombs test.